Good morning, everyone, and welcome to our webinar, and thank you for joining us. So I'm Hira Naveed. I am the chair of the Royal Statistical Society Official Statistics section, one of the joint organisers of the series of webinars. In the webinar today, we will be discussing a really important topic being mental health statistics. I'd like to thank the speakers in advance for their time today and sharing their work in this remit. I'll now hand you over to Dina Letterbetter, the chair of the Health Statistics User Group, who will chair this webinar today. But before I do that, I would also like to thank Dina and others in the working group for a sterling job as ever for organising this very great session. Over to you, Dina.
Right, thank you very much, Hira, and welcome on behalf of the Health Statistics User Group. And as always, we're very grateful to the RSS Official Statistics for hosting this and enabled us to run this series of webinars. I would like to, I think we've probably got quite a few people joining that haven't participated in one of our webinars before. So just running through a little bit of the housekeeping. If everybody could stay muted throughout the webinar, that obviously helps. The way we run the questions is that if people can put those during the chat, ideally indicating if it's directed to a particular speaker, then we run through all the presentations, and at the end we have a Q&A session where we pick up on the questions. The meeting will be recorded, also which will be posted on the website once it's available. The presentations and a report of the meeting will be posted on our website, which is in HSUG, which is within Stats Usernet. So you go to Stats Usernet, look at webinar materials. We also do a report of the question and answers. So if there's anything throughout the webinar that you want to follow up on afterwards, then it will be posted on the website. You don't need to sort of take notes. But feel free to also post things yourselves. If you put anything on the chat, we will capture that and put it in the report. So that's the general sort of housekeeping side. Can we have the next slide, please? Our approach to the webinars is that this is very much part of an ongoing collaboration, exchange of ideas. So not only what you're listening to today, which I think will be very interesting from seeing what the speakers are going to say, but also from looking at what's posted and from ongoing discussions. I think, this is part of a continuing exchange of ideas. We're particularly interested that today we have actually we've posted information about the webinar on the Analyst X community. So I hopefully welcome particularly to people who've joined from that. This is the first time we've actively tried to engage them. And hopefully we'll be mentioning the theme group, that between the theme group, we're trying to bring together communities of interest. So there may be connections and relationships that we can follow up after the webinar. So it doesn't finish at the end of the webinar today. It's a continuing thing. Right, the next slide, please. So that's probably enough in terms of the general introductions. The speakers you will have seen on the publicity. Tim Vizard from ONS, who's talking about survey data to get early insights into mental health during the pandemic. Then David Fisher, who the sharp-eyed of you will notice has changed allegiance in the publicity. It was NHS Digital, but from the beginning of this month, that is now part of NHS England, who will be talking about access to mental health services during the pandemic. Then Emma from ONS will be talking about linking administrative data sets to give greater insights, and we'll also mention something around the theme group on mental health statistics and how people can get involved and how that works. And then last but very much not least, we have Sarah from Scottish Government, who will be looking at moving on from COVID and the future of mental health equalities and outcomes in Scotland. So that's probably enough from me, and I will just hand over to the first speaker. That is Tim, and look forward to hearing from you, Tim.
Thank you very much, Tina, and hello everybody as well. So yes, as mentioned in the introduction, the session that I wanted to talk about today was how we've been using survey data to get insights, and particularly early insights, into the mental health and well-being of adults and children during the pandemic and beyond as well. So if we move on to the next slide. So in a bit of background, and potentially not surprising to many people here as well. So in early 2020, the COVID-19 pandemic brought a new need for data and research. So it brought a lot of challenges, and within that, it brought us also the need to provide kind of real-time data, really timely data to understand current lived experiences of people in the country. Our existing data evidence base was still really good and really important, but it was also that need for what was going on in the current situation as well, and the changing situation, that was really important. So we, as a kind of a research, a statistical community, came together to provide timely estimates across a range of these issues, some really kind of closely aligned to COVID-19, the illness itself, around infection rates, around hospitalization and mortality statistics, and then later around vaccine uptake and efficacy of the vaccine. But also there was that need for sort of the wider issues around COVID-19, and particularly the societal impacts that the COVID-19 pandemic was having on daily life. And particularly for this session, talking about the mental health and well-being of both adults and children. So if we move on to the next slide, and I'll focus first on children, and particularly looking at one study that was conducted at the start of the pandemic by our colleagues in NHS England, at the time known as NHS Digital. And that was a kind of a collaboration across many different organisations, including the ONS, also National Centre for Social Research, and the colleagues at University of Exeter and Cambridge. And this is part of a wider series of mental health statistics published by NHS Digital. I won't go into too much detail about the wider series, as I believe David from NHS England is going to talk a bit more about that in his presentation. But essentially how this study was set up to respond to the pandemic in 2020. So being able to collect data in July 2020, those early days, to understand the mental health of children and young people. It followed up around 3,500 children who took part both in 2017, but also in 2020 as well. And being an online survey, predominantly the parents, but also getting the views of children and young people when they were old enough to take part. And this enabled us to look at rates of probable mental disorders in children using something called the Strengths and Difficulties Questionnaire, a tool that's developed by Youth in Mind. And the headline number that came out of this research was the rate of probable mental disorders in children. So in 2017, we found 1 in 9 children, that's 5 to 16-year-olds, experience a probable mental disorder. So in 2020, that number seemed to increase to around 1 in 6 children aged 5 to 16 experiencing a probable mental disorder. Can we move on to the next slide, please? So looking at that kind of sample of children in England, we looked at 5 to 16-year-olds firstly, in particular, just focusing a bit on some of the findings about the lived experiences of these children. And one of the benefits of this survey, being kind of a snapshot in July 2020, was enabling to kind of understand that experience at a specific point in time when lots of things were going on in an ever-changing kind of environment. And we found that 5 to 16-year-olds with a probable mental disorder, they were more likely to live in households that had fallen behind with payments, so around 16%, compared to around 6% of those without or unlikely to have a probable mental disorder. And when we look at 11 to 16-year-olds, we found over half, 54%, said that lockdown had made their life worse, those with a probable mental disorder, compared to around 40% of those unlikely to have a probable mental disorder. And on the next slide, we also had a look at 17 to 22-year-olds, so young adults. And one of their kind of experiences we found there was that we found that 17 to 22-year-olds with a probable mental disorder, they were more likely to report their household could not afford to buy enough food or had to use food banks, around 10%, compared to 1.6% of those unlikely to have a probable mental disorder. So this kind of just provides a bit of a snapshot and some of these kind of early findings that we were finding from survey data that was set up quite rapidly during the pandemic, but also kind of using kind of really robust statistical techniques with a random probability sample and using the kind of the benefits of some of our kind of official statistics as well. On the next slide, then I'd like to talk a bit more about not just children, but also adults as well, and how we use survey data to get those early insights into the mental health of not just children, but adults as well. And one of the tools we used for this was something called Our Opinions, a Lifestyle Survey. And this is a study that's been running for many a year in ONS. But in March 2020, it was adapted from what was a monthly survey to a weekly survey tracking the social impacts of COVID-19 pandemic. And this had lots of things it was capturing, and it was also a cross-sectional survey of adults aged 16 and over in Great Britain, and it being an online self-completion questionnaire with some telephone interviews available on request as well. And this survey and the screenshot of the kind of the landing page for the survey there, it was done in a very quick turnaround. So the survey would typically launch on a Wednesday, close on a Sunday. Then Monday morning, bright and early, we had a team of researchers kind of analysing that data, starting by data processing it, cleaning it, doing the data checks you would expect from a normal survey. And then that data being weighted to be representative of the population. It was the target population, and calibrating as well to population groups. And then that was analysed and published just a few days later. So a survey that would close on a Sunday would then be published on a Thursday or a Friday, currently on a Friday. So just a few days after the data becoming available. So making sure that we're getting those really early insights out in an ever-changing environment. And if we move to the next slide, one of the things that we did track was personal wellbeing. Some of you might be familiar with the measures of personal wellbeing that the ONS publishes, around 4 domains, which you can see on the chart on the right. But pre-pandemic, ONS published these on a quarterly basis and an annual basis. And this provided a really kind of good retrospective look into kind of people's mental health, into people's well-being. But what we found in the pandemic is that we needed kind of data that looked at the kind of current situation. So to do that, we were publishing weekly data on personal well-being, and that was provided some really interesting data. So it kind of almost highlighted some micro changes that would often kind of go unnoticed in kind of data that is on a quarterly or annual basis, that smooths the kind of zigzaggy lines, but those kind of noise in the data actually, when we delve a bit deeper on the next slide, kind of shows some really interesting patterns as well. So focusing on one of the measures on anxiety, so how anxious did you feel yesterday? And this measure is one which a higher score, closer to 10, highlights higher levels of anxiety. And taking just 3 time points here. At the start of the data we collected on a weekly basis, so at the end of March 2020, we found that there was a really high level of anxiety, mean anxiety in the population. And if we ever think about what was going on at that point in time, it was the point where we were being asked to stay at home. We were in a period of lockdown just being launched in the country as well. So understandably high levels of anxiety. And kind of the change that you see through the year then is really interesting. But if we go to the next dotted line there, you can see another spike in anxiety that came towards the end of 2020 and early 2021. And this, not just maybe seasonal, but actually probably was driven by the introduction of the Delta variant to our lives. And again, a period of sort of a change in environment in terms of what we could and couldn't do due to the COVID-19 illness and pandemic. But then when we kind of see a similar pattern emerging through 2021 and then 2022, at the start of 2022, we do see another small spike, but nowhere near what we were seeing in terms of anxiety in the previous years. And this could again be seasonal, but it could also be the point when Omicron was also kind of coming into our daily lives and maybe the uncertainty that we were living in. But by having this kind of timely data on a weekly basis, we can see some of those peaks and troughs that were happening, which might otherwise have been missed if we were looking at it on a weekly or an annual basis. And just to kind of reiterate that scale on the y-axis there is the mean score of anxiety, where a score of 0 is low anxiety and 10 is high anxiety. So it's the mean level of anxiety in the population. If we move on to the next slide, as well as personal well-being, we also looked at rates of depression in the population. And this was using kind of our PHQ-8 score. So some of you might be aware of the PHQ-8 mental health screener. It asks a series of questions that help us understand whether the likelihood of someone may have some form of depression. And we asked these questions on our opinions and lifestyle survey before the pandemic in July 2019 to March 2020 as part of a wider piece of work that we were doing. But we also then were able to go back to the same group of adults in June 2020 to try and answer the question, have we seen a change in rates of depression in the population? And from this, we were able to calculate a score of those with no or mild depressive symptoms and those with moderate to severe depressive symptoms. And you can see here on the right that what we found was almost a doubling in rates of depression from around 1 in 10 before the pandemic to 1 in 5 during the early stages of the pandemic. And on the next slide, what we were also able to do is look at the same group of adults. We could look at individual level change as well. So the vast majority of the population using this kind of rather binary, but still useful to present in this way, scores of no or mild depressive symptoms and moderate to severe depressive symptoms. We found around 77% kind of persisted with no or mild depressive symptoms, but we saw nearly 13% develop moderate to severe symptoms since the pandemic. We also saw around 3.5% show signs of improvements, moving from moderate to severe depressive symptoms to no or mild depressive symptoms, while just over 6% continue to experience moderate to severe depressive symptoms in both time periods. And on the next slide, we have been continuing to ask these questions on depression on our opinions and lifestyle survey to understand whether this was like a temporary blip or whether it's part of a longer term trend. And what the chart shows on the right here is that almost doubling, or that doubling of rates of depression kind of can be seen in 2020 and then throughout early 2021, where there's a slight increase again. But then throughout late 2021 and into 2022, we've seen a kind of improvement or a decline in rates of depression. Whilst that, you know, is a positive thing to see, it's also potentially not back to where we were seeing before the pandemic. And the reasons for this are probably going to be multifaceted and quite complex. But one thing that has happened in this time is that we've not just had the challenges of COVID-19, but also the introduction of the cost of living challenges that people have been facing. And on the next slide, we've explored this in a little detail as well. So we're not able to attribute causality and say one thing's causing the changes in rates of depression, but we've asked people about their kind of experiences dealing with the increasing cost of living and asking people particularly what actions they've taken due to increases in the cost of living. And what we found here is that adults with moderate to severe depression, they were more likely to tell us they were spending less on food shopping and essentials. They're also more likely to tell us they're using more credit or using credit more than usual, for example, credit cards, loans or overdrafts. They also said that we're more likely to tell us they're spending less on non-essentials. And although small numbers, but probably very stark numbers as well, they're more likely to say they're using support from charities, including food banks as well. So on the next slide, and I'll just come to a close on these last couple of slides, we've been talking about all of these things that we've done during the pandemic, but also it's important to think about what we do to monitor our mental health and wellbeing before, beyond the pandemic as well. And one way we're going to do this is not only through our kind of surveys that we publish and our fortnightly insights from our opinions and lifestyle survey, but in ONS, we also publish our quarterly Measures of National Wellbeing dashboard. This covers a wide range of indicators that matter to quality of life that were formed as part of a national debate around a decade ago, identifying what are the key things that matter to our quality of life in the UK. We have a framework for children, we have a framework for young people. But on the next slide, I'll just show you some of the indicators on our framework for adults as well. And there's lots of them here. And I think I won't go through all of these in the interest of time, but just so you can see the range of indicators that we use to track people's personal well-being, their quality of life, their mental health. And a lot of these are kind of been identified as associated with our quality of life. But we're also looking to review how we publish these statistics. So on the last slide, what we're currently undertaking is a review. So over a decade has passed since we came up with these indicators, and we've had a lot of change during that period as well with the COVID-19 pandemic and also the rising cost of living. So what we're looking here is reviewing the indicators we're reporting on and also how we communicate these as well. Over the last few years, let alone the last decade, we've seen lots of really good new data sources coming available and really novel and innovative ways that we can communicate these statistics. So we're undertaking this review at the moment, and we're going to publish some initial recommendations in spring 2023 as part of our wider work of how we continue to track kind of mental health and wellbeing during the pandemic and beyond. And with that, thank you very much for your time.
Thanks very much, Tim. And it's a lot to cover there. So obviously just reminding people the slides will be posted so you can go back and look at them afterwards. And thanks, there's lots of queries and comments coming in on the chat. So keep that up and we'll come back to that in the Q&A session afterwards. But without more delay, I'd like to hand over to our next speaker, which is David Fisher from previously NHS Digital, now NHS England. David.
Yeah, so I'm David. I'm one of the principal analysts now NHS England, previously NHS Digital, working mainly with mental health data. I mean, mainly from the mental health services data set. And I'm going to talk to you a bit about access to mental health services in England during the pandemic. Can I have next slide, please? So I'm just going to cover a few of our publications, mainly the bulletin, some of our monthly statistics and a bit more the survey data that we've talked about, and then just touch on a couple of other sources of data that we've got out there as well. Can I have next slide again? So yeah, next slide. So the mental health services data set has existed. Can I have next slide while we go? Since 2016, January 2016, previously it was the mental health and learning disabilities data set, and before that it was the mental health minimum data set. So we've had mental health data covering secondary mental health services since around 2011. The data that started to flow in 2016 was kind of extending in scope so that it now covered children. And effectively, this is the definition of the scope from MHSDS now. So it's a patient level, output-based secondary uses data set delivering information for children, young people and adults who are in contact with secondary mental health, learning disabilities and autism services in England, all located outside of England, but where the treating patients are commissioned by an English CCG or NHS England specialised commissioner. Can I have the next slide? So this slide gives you kind of an indication around the number of people in contact with services at the end of each month and the number of submitting the data to MHSDS. So data to the end of April 2018 is kind of quite stable. We're around 1.2 million people in contact with services. And then from 2018-19, there was kind of an increased drive to improve the coverage of the data set. And you can see there that 106 providers submitted data in April 2018, and that by April 2019, that number was 210. And the number of providers has kind of continued to increase. We hit 285 in April 2020, and across 2021 and 21-22, the numbers increased to over 300, with around 350 providers a month now submitting data. Equally so, that's kind of to give you some context around the number of people in contact with services increasing, but also to kind of just flag that the increase in coverage kind of explains some of that. But we'll look at some more comparisons soon, and you can see there the first indication of where UK lockdown starting in March 2020. Can I have next slide, please? So this just gives you kind of an idea of what we cover using the mental health services data set. So we've got the mental health bulletin, which is an annual publication and covers people in contact with services, people in hospital, and a variety of other topics. We've got a publication which purely deals with the uses of the Mental Health Act. We've got a monthly publication which also covers a lot of what's in the bulletin, but just is more timely. We've got 2 dedicated publications which cover autism and learning disabilities. We've got another for out of area placements, and then finally we've got the excess under 75 mortality rates as well. Next slide, please. So I just wanted to give you this slide next, and it's just to highlight some key dates, especially around lockdowns. So the key dates are on the top, really, the 28th of March 2020, and I think it's the 5th of November, and around December where the second lockdown starts. So it's just to give that context around the actual dates when that when those happen. So it was the 5th of November 2020 for the second UK lockdown. So when we look at some of the data in a minute, like those dates are kind of quite important. So next slide, please. So I'm going to start and just talk about the bulletin a little bit. Can I have next slide? So the latest iteration that we published in November was the bulletin 21-22. Can I have next slide, please? And the bulletin covers wide variety of topics, like I've already touched on there, and there's a list of kind of things that we touch on there. The bulletin also has a lot of breakdowns at a lower level than England, so you can look at kind of ICB level data, that is STP data, and CCG data. We also do a lot of demographic data and a lot of rates in the bulletin. Can I have next slide, please? So the slide here gives you the proportion of people in contact with some secondary mental health services over time. And you can see that over time, the proportion of people in contact with secondary mental health services is increasing generally. The interesting year, I guess, is what happened in 2020-21, because you can see for children the rates were kind of increasing, especially between 6 to 10 to kind of 19 and 20. The pandemic kind of produced a year where people in contact with services dropped. So you can see for 6 to 10 that rate dropped slightly. You can see it again in 11 to 15. And interestingly, again in the older populations as well. So 50 plus, you can see the drop in 2021.
It's interesting.
There as well. And then actually after the
time, I was talking about demand
in the pandemic afterwards in 21-22, things bounced back quite a lot more. So especially in the younger ages, so 11 to 15, 16, 17, 18 and 19, those rates have increased quite substantially and in a way are in line with what we're seeing in the secondary, in the children and young people's mental health survey. The only thing here is that we can't actually know whether the trend, like the increasing trend, would have happened regardless of the pandemic or not. So it's something to think about there anyway. Can I have the next slide as well, please? So this slide gives you the number of admissions and discharges in 21, to kind of going back through the years of the bulletin. And admissions and discharges dropped in 2020-21, and we'll look at it in a bit more focused detail using the monthly publication in a minute. But discharges dropped by nearly 14% from around 125,000 to 107,000 between 2019-20 and 2021. The number of admissions also decreased in this period. In 21-22, the numbers kind of remained fairly static. Can I have next slide, please? So I'm going to talk to you a bit about the monthly next and some of the findings in there. Next slide again. So the monthly publications run since January 2016 and is published monthly. It covers an awful lot of data now. So I think I've put over 100 there. I think we're nearly at 200 soon, I think. We've also got some other data in there around kind of quarterly data that we produced, where we link with the maternity services data set to give numbers of new or expectant mothers in contact with mental health services as well. So can I have next slide? So this was the slide where we talked about the number of people in contact with services at a top level early on in terms of the coverage, but you can see in the data kind of pronounced effects of lockdown where numbers dropped substantially once lockdown was announced. So you can see the big drop for the first lockdown, and then actually for the second drop for the UK lockdown, kind of there was a drop there, but it was not as substantial as the first one. Can I have the next slide as well? And then the other, so this slide gives you the number of attended care contacts split by consultation medium, and you can see that kind of in the period between April 2019 and March 2021, there's a definite shift in the way that contacts are kind of undertaken with people. So prior to the first lockdown, the majority of contacts were done face to face, mainly. So that's the dark blue bar, and then following the first lockdown, there was a definite shift towards telemedicine appointments and telephone appointments. So telephone appointments are the dark grey, and then the light grey are telemedicine or web camera appointments. So that's one of the key shifts that we've seen in the monthly data. Can I have next slide, please? So this is the slide we talked about before, where it shows the number of admissions and discharges, and there's a definite spike and kind of in the number of discharges, which kind of coincides with the first UK lockdown. And again, the admissions drop at the same time, and it takes a few months for that to kind of sort itself out and kind of trend with each other going forwards. The impact of the second lockdown is not as pronounced, so it feels like in the data that once that first lockdown has the big impact in the data, and then following that kind of there's less impact. Can I have next slide, please? So I'm just going to touch on the mental health of children and young people a bit more again. So next slide, the Mental Health of Children and Young People survey provides mental health prevalence data for children and young people in England. There's been 3 surveys, one in 1999, one in 2004 and one in 2017. The main survey involves the face-to-face surveys and a lot longer. In 2017, it was covered 2 to 19-year-olds, and parents and children and young people and teachers took part. The survey uses the Development and Wellbeing Assessment as a tool for mental health prevalence. However, we also use the Strengths and Difficulties questionnaire. This survey is slightly shorter and easier to complete, and therefore it lends itself to the kind of being an online survey. And in the follow-ups that have taken place in 2020, 21 and 22, the Strengths and Difficulties questionnaire is the measurement used for mental health prevalence. Also, just as a follow-up cohort are getting older with each survey, so the cross-sectional analysis is updated for each publication. So the 2020 cohort is 5 to 22-year-olds, the 21 are now 6 to 23, and the 22 cohort is 7 to 24-year-olds. Can I have next slide, please? So in 2017, 1 in 9, or 12.1% of children aged 7 to 16 had a probable mental health disorder, and it rose to 1 in 6, or 16.7% in 2020. It's remained stable at 17.8% in 21 and 18% in 22. For 17 to 19-year-olds, in 2017, 1 in 10 of young people had a probable mental health disorder. And again, this rose to 1 in 6, or 17.7% in 2020, and has remained stable since. Of the 9,500 people asked in 2017, 7,500 agreed to be kept on file and were asked in subsequent years, and reporting's based on those cohort ages. Can I have next slide? So the follow-up survey took place in July 2020 and asked the following question. Since the 1st of March, has the coronavirus pandemic meant that you've decided not to seek help for any concern over your mental or physical health? And the question's asked of parents about the child's mental or physical health for 5 to 16-year-olds, and is asked directly to the young person for 7 to 22-year-olds. And what you can see in the graph is kind of following the pandemic, there was a lot of people, especially those aged 7 to 22, who didn't seek help for either a mental health or physical concern, or didn't seek help for a mental health concern. And I think that's one of the findings from the 2020 survey there. Can I have next slide, please? So the other question that was asked, since the 1st of March 2020, have any of the following happened in relation to contact with services or professionals about your mental health or emotional behaviour or concentration problems? And it's again asked of parents for children aged 5 to 16 and the young person themselves for those aged 17 to 22. Just to note here that sometimes the totals can be more than 100% because you can select more than one appointment. For example, if you had an appointment that was cancelled and then another one that was also changed to be video or phone. And you can see actually that this kind of is in line with what the monthly publication was showing. So a lot of people, nearly 18.5% of 17 to 22-year-olds had an appointment that was changed from face-to-face to video or phone. There was a large number who kind of still received help from normal services. And then there was also quite a lot of people, 17.5% of 5 to 16-year-olds and 21.7% who tried to seek help but did not receive the help that they sought. Can I have next slide, please? So just to touch on some other sources of mental health data that we've got published. So, this is a bit out of date now, so it should be NHS England also publish a range of data relating to other areas of mental health. So we publish data on talking therapies. We've also got the adult psychiatric morbidity survey as well. Can I have next slide? And then I've just put some useful contacts and links going through. So we've got the email addresses for the mental health analysis mailbox. So that's any questions related to mental health services dataset. We've also got the surveys, queries, mailbox there in case anyone's got any questions around the children and young people survey or the adult survey. And then over the next, I think it's the next 3 slides, we've got some links to different publications that we've touched on today. The third link is just the link to the lockdowns as well. But otherwise, that's it from me.
Thanks very much, David. Yes, once again, a massive amount of content there and things to follow up on afterwards, probably for people. And lots more comments and queries coming in, including, I seem to be looking like I'm asking questions. I don't know if someone else is masquerading as me, but questions are good, whether or not they're down to me or down to someone else. Okay, now just passing on to the third speaker, Emma Sharland, who's going to be, well, she's going to tell you what she's going to be talking about. It's on her first slide. Over to you, Emma.
Thanks, Dina. Hi, yeah, so I'm Emma Sharland, so I'm the head of the mental health analysis team within ONS, and I'm going to be covering kind of the work that my team are currently working on and future planned work as well. So won't cover a huge amount of results in terms of publications, but it will show you what's sort of coming up in the future, and hopefully it will be some publications that you'll be interested in and keen to get the results of when they are published. So if you could move on to the next slide. So the focus of my team is to provide greater insights into mental health using linked administrative datasets. So predominantly at the moment we're using the IAP dataset and using things like the Census to provide more insights into people that are using that service. I will go into that publication in a bit more detail in a moment, but we're also aiming to address any gaps in evidence that we can with the linked administrative datasets that were identified within the OSR report into mental health statistics in England. So we are developing our work plans to make sure that we can address some of the key recommendations in that report and fill in gaps where we can. And the work of the team is increasing in volume. So we will be publishing soon a current and upcoming work plan on the ONS website so that stakeholders and users can be aware of the progress of the work and what's upcoming and what will be published in the near future. Next slide, please. So to start with, going over a few of the kind of work streams that we're working on at the moment. One is the mental health and the pandemic kind of work stream. So we published back in 2021 a publication looking at coronavirus and GP diagnosed depression in England. So when the slides are shared, the link will be available to you to read that publication if you've not seen it previously. But the work that we're currently working on is using the Open Safely platform in collaboration with academics from Manchester University, Swansea, London School of Hygiene, Tropical Medicine and Oxford University to look at the mental health outcomes following COVID-19 infection. So we're being able to, on this platform, be the first project to link the COVID-19 infection survey, which is run by ONS, to primary care data to look at mental health outcomes in those who were infected with COVID compared to those who were not infected. So analysis is underway with that, and we're hoping to get results fairly soon. We don't have a date currently for publishing this work, but hopefully it won't be too long, hopefully in the first half of this year. Next slide, please. So the other stream of work that we are working on is around common mental disorders and the inequalities in accessing services. So we published last year in June a publication looking at socio-demographic differences in using the IAPT service, linking IAPT to the Census in 2011 and then comparing treatment rates in IAPT to the prevalence of a CMD in the general population using the UK Household Longitudinal Study. And the data that's presented to you on the table there shows the groups that were most likely to be accessing IAPT with common mental disorders, and then the groups that were least likely to be accessing IAPT. And these are probably the groups that are of most interest at the bottom there. So as you can see, older adults, males, people from an Asian ethnic background, people with a religion, those who are disabled, born outside the UK, and English not being the first language were groups that were least likely to be accessing IAPT services. And therefore, this might indicate that future improvements to the service and any targeted kind of recruitment into the service may want to focus on those groups to help them have access to this treatment. Next slide, please. So continuing on the work that we've been doing on this front, we're looking to repeat the study that I've just gone over with later years of data. So just to note that the analysis that we published in June was using the 17-18 financial year of data. So we're looking to use the later years of data to see how that the groups accessing that service have changed. And this will also then include that first year of the COVID pandemic, the 2020-2021 year. And so it'd be interesting to see how access to the service has changed during the pandemic, and any groups that may be more in need of support to get into IAPT services. And we'd hope to expand the work further as well into looking at outcomes as well as just accessing the service. Sorry, next slide, please. So to cover the work stream that we're doing on suicides, before I go into this, just to note that my team do not cover all work done on suicides within the ONS. So there's the lifestyle and risk factors analysis branch, who we work very closely with, who cover suicides predominantly in ONS, but we are collaborating with them on a few projects, and also there's some projects presented on this slide that are done in the wider health modelling hub, which where my team sits within ONS. So recently there's been a publication looking at suicides among people just diagnosed with severe health conditions in England. And we're working on a few other projects in my team at the moment, which is looking at the analysis of socio-demographic risk factors of suicide in adults. So this is using a large nationally representative sample. We're also looking at the risk of suicide following bereavement in families, and also a project which is a qualitative project, so a slightly different approach for us, using prevention of future death reports. These reports, if you're unaware, are reports that are submitted by coroners following their assessments, and we're specifically looking at reports that are categorised by suicide during January 2021 and October 2022. And we're hoping with this project that this will enable us to identify any kind of themes and patterns and recommendations that are coming out of these reports submitted by coroners, which can hopefully inform future suicide prevention strategies. Next slide, please. So predominantly the work that I've covered so far has used the 2011 census, but we are looking to move forward using the 2021 census in our analysis. So one of the projects that we're just starting to, I guess analysis should be starting fairly soon, is around research on mental health outcomes in the LGBTQ+ population. So this study, we're hoping to link the 2021 census with other administrative datasets, so including IAPT, the hospital episode statistics and death registration data, to understand in this group how they use the service, how they use the treatments and their outcomes and their treatments too. And we have future plans to expand this work into other groups. At the moment, we're considering veterans, ethnicities, different people who are disabled versus not disabled, and maybe by different occupations as well. We're not limited to those groups, and if there are particular groups that are of interest to people, we'd be more than happy to discuss and potentially collaborate on projects. And we would, we're happy to sort of consider other groups if that's of interest. But as I say, we're starting with the LGBTQ+ population, and hopefully that research will be published this year. Next slide, please. We're also collaborating with the adult social care team within ONS, and currently we're working on a project that's investigating the risk of death during the COVID-19 pandemic in people with dementia compared to those without dementia by place of death. So we'll be using the ONS's public health data asset to conduct this research, and that project should be published by the end of March. And then our future plans are to acquire the mental health services dataset within ONS so we can expand our work, linking the administrative datasets to cover other secondary mental health services. We also want to focus more on mental health in the labour market as well. And we seek to explore further routes for funding for projects and welcome any feedback on these plans and open to collaborating on projects as well. And as I've mentioned at the beginning, we are looking to publish soon a mental health and suicide's current and upcoming work plan. Next slide. And then just to finish off, I'm just going to cover off a bit on the mental health theme group. So the lead for the theme group is Cher Cartwright in NHS England. The central contact for anything relating to the theme groups is the gss.health@ons.gov.uk mailbox, which is something my team also cover. So if we can move on to the next slide. So just to give a bit of a background on the English Health Statistics Steering Group and the theme group. So the group itself was developed on the recommendation of the Office for Statistics Regulation, and we feed into the Head of Profession Health Statistics Leadership Forum, and below the EHSSG is the 15 different topic level theme groups, of which mental health is one of them. And the aim of the overall group and subsequently the theme groups is to increase coherence, production, dissemination and accessibility of health and care statistics in England. So we want to bring together different agencies working on these topics to make sure that things are not being duplicated in different areas and ensure that all health policies are evidence-based. So there was a period of time during the pandemic where a lot of the coherence work was paused. So in the last year, a lot of the theme groups have been relaunched. If you could go to the next slide. So I've just highlighted on this slide, I won't go into each of these in detail, but the overall EHSSG aims. So they are covering things like coherence and making sure that we work with users for statistics to ensure openness and transparency. And I can provide some links after my presentation to the web pages where you can find our aims, the work plan, and links to the theme group information as well. Next slide. So in terms of the mental health theme group, they're in the position at the moment where they're in the process of agreeing a new action plan for the group and building off of the previous agreed actions that the group had a couple of years ago. So the actions are on that were previously held by the group are on the slide there. So it was to coordinate publications and analysis, improve accuracy of data, harmonise methods and definitions, and a user engagement aim as well. And then if you could pop to the next slide, in terms of the previous successes of the groups against each of those aims, there's been a better awareness of what each organisation does and the upcoming work and outputs that have been produced, and they are working together to ensure analysis remains relevant and is updated. There's been collaborative work to improve data quality of the mental health services dataset, and particular to achieve joint data quality improvement plan and how to remove duplicate data collections. In terms of harmonising methods and definitions, the group examine methodology issues and have a consistent approach as far as possible and appropriate, and the group will also share methodologies when they meet. And then in terms of user engagement, there's the Mental Health Data Hub, as David mentioned, which is a central place to signpost users to data that's available across the system and to promote the use of the Data Hub and seek user feedback for improvements as well. So that's the last slide from me. Happy to take any questions at the end, but I'll pass back to Dina now.
Thanks very much, Emma. And obviously, in terms of user engagement, these sorts of webinar and establishing these community and these links is also a very important part of user engagement. So any input and thoughts and comments from anybody around how you can get more engaged with the theme group would be really welcome. And I know there's lots more continuing to be posted on the chat. So our final presentation is from Sarah Martin from the Scottish Government, who's going to be talking about moving on from COVID and the future of mental health equalities and outcomes. Over to you, Sarah.
Hello, thank you for having me. So this has been such a fascinating lunchtime, I think. And when I first proposed that we run a session at the RSS conference, which would have been in person in September, but we were not able to attend because of the Queen's death in the mourning period that it fell into. But I'd really set out to look across the UK at what work is going on in mental health statistics. And when we started putting the speakers and the sessions together, it became quite clear that we had stories to tell that involved sort of the real-time data of what is actually happening with people's mental health in a time of crisis, which was outlined in our first talk today. And then really moving through the sort of longer term research that can be done on this really quite extraordinary time. And I want to finish today by talking about where that leaves us going into the future. And this is going to be a slightly different talk because I work in what is now a policy role in the Scottish Government, looking at the future of mental health services. And COVID has really put us into quite a unique position in the last decades, in that suddenly everyone's attention was on mental health and people's attention was on, we don't have enough mental health data to be able to say what we want to be able to evidence what we need, particularly around equalities and outcomes of people. There's a lot of data around systems and services, around patient volumes, but not necessarily what those patients actually receive, experience, and what happens to them afterwards. And so I'm really delighted to see some of the data linkage work linking across to census records and some of the work linked to mortality records, etc., to really start to be able to put together research data sets that unlock this all. But before I keep talking in broad terms, what I wanted to say is that we have currently got policy-wise a focus on mental health that we haven't had, and a lot of input from stakeholders as to what mental health care really ought to look like in a country. So I would like to just start by outlining on the next slide, please, what the key themes are that we're taking forward. And so this is results of a number of stakeholders getting together and putting forward a recommendation for how we should shape mental health policy. So the first point is that we should promote good mental well-being. The second is that we should prevent poor mental health and distress. And the third, which is my bag in services, as have the other talks been, is around providing appropriate support and care. Now, there are a number of products that the Scottish Government is working on. They're currently out for consultation. There's a new strategy that has been out for consultation that is in draft, due to publish in 2023. There are standards for secondary adult mental health services that are currently out for consultation. There are specifications for psychological therapies that are also currently out for consultation. There are all these products that are looking to publish in the course of 2023, and that will need to have some measurement attached to be able to identify whether the implementation is successful, and some form of baselining and some sort of evidence at the end to say these are the changes that have happened in a positive way for patients throughout through the implementation of this work. So looking into these themes in a little bit more detail, just to set the scene. On promoting good mental well-being, we've been asked to deliver an ambitious public health programme to promote good mental health and well-being for the whole population. This would include developing community supports, using asset-based approaches to adopt and maintain healthy lifestyles, raising health literacy, and creating the environment and social conditions that will allow well-being to thrive. Now, with our measurement hats on as statisticians, this is really squarely health surveys territory and health behaviours, which we have in place to some extent, but we're really looking at population level indicators of general health linked to mental health indicators. Next slide, please. In the prevent space, we've been asked to identify and target specific actions to tackle key risk factors across all policy areas for communities and populations at higher risk of mental ill health and distress, such as inequality groups. This includes reducing economic insecurity, educational disadvantage, and unequal access to the natural environment. Prevention must also include sustaining and expanding self-management and peer support initiatives. This will enable those with lived experience of mental ill health and distress to maintain their recoveries and reduce risk of relapse. Now, how do you put measurements around this? This, for me, as a statistician, this sits squarely in research territory and in focus groups and in I guess, quite small specific pockets of what prevention even works. What do we even mean by prevention? I have to say this one absolutely flummoxes me. I've put my email address in the bottom corner. If anyone has any clever ideas or has done any of this work, please get in touch. I'd be really curious whether there is a national indicator approach that could be brought to prevention. Thankfully, this is not currently on my list of objectives, but it's not something that we can shy away from longer term. On the next one, which is more my comfort zone in terms of providing appropriate support and care. So that is my background. So we've been asked to make a full range of flexible recovery-focused support and treatment options available to meet the individual needs of those who experience mental ill health and distress. This should include innovative specialist crisis services, national distress services, access to sufficient, adequately resourced and locally based inpatient services, and also home and community-based alternatives within both statutory and third sector delivery. Early intervention, person-centered care planning and peer support must be key every time for every person. And this is where we go into the territory of the kind of data that we've already been speaking about. We're looking at patient level information that tracks patient journeys and tracks equalities as well. And that is something that we are developing in Scotland. It's been in the making for a wee while now. It was commissioned in 2019. We've had some data published a couple of years ago, but our completion, the data quality really isn't where it needs to be to have an actual national collection that's publishable at detail at this point, but we're working on it. And the main work is around infrastructure and systems that are available for people to input into. If the right questionnaires aren't in the clinician's drop-down menu, then there's not a lot they can do about it. So, and with it all sitting in different trusts and boards, there's quite a lot of, quite a disparate task, let's put it this way. So, in general terms, I would like to talk about what we've been asked to do. So we've been asked to be ambitious. We've asked to focus on early intervention, focus on recovery, on community need. We've asked to have a no wrong door approach, that no matter where people seek help, they get it. We've asked for parity with physical health. This has been an ambition in Scotland for quite a long time. We've asked for it to be lived experience led, which all the policy work that's currently up for consultation certainly has been, and something that enables patient choice. We've asked for human rights based approach to this, based on protected and other equalities, reducing inequalities, and the whole thing really under the umbrella of anti-stigma. Now, this is what we've been asked to do. and evidence, which ultimately to me means measure. Now, I'd like to contrast with that and show you what we've currently have been measuring. We've been measuring quite a lot of things, but the main political measure that gets reported in the press and discussed in Parliament on a quarterly basis is that 90% of patients should start treatment within 18 weeks, which has been a government commitment for about 10 years now. And that really measures such a small part of I guess, simply the waiting time. So the key national measure of are our mental health services doing what they ought to do? Are they the best they can be? Is wrapped up in this percentage of patients that start treatment within 18 weeks measure. And we understand that this is important and it has served us very well in terms of funding towards mental health and mental health being discussed in Parliament and being at the forefront of health thinking in recent years. However, as a measure, there are some issues with it, which I'd like to show in the next slide. So if we have a measure that says that a certain percentage of people should start treatment within 18 weeks, to all of you, it'll be pretty clear that this is something that could really easily be met. So a service can receive 100 referrals and have a couple of hundred people on a waiting list. As long as they offer treatment to 20 people who've just come in the door, they could easily be at 100% continuously and just keep building a waiting list. So with everything that we introduce as a measurement, we need to be really mindful of the unintended consequences and of whether we are whether our measurement in almost a quantum mechanical way is impacting on our experiment. So is the fact that I'm measuring this this waiting times target in this way means that I am inevitably building my waiting lists. Now, thankfully, clinicians don't care as much about the waiting times targets as some other people do. So they will base on risk and on patient need rather than on how long they've been waiting. However, you can see how introducing a measurement can have detrimental effects, but also how actually introducing an intelligent measure at this stage, while we have all these documents out for consultation, how that can really promote best practice and draw attention to what's actually important. So for me, this exercise is not about measuring everything we can measure. It's not about even measuring everything that we're interested in. And it's actually about measuring some things that we're actually not that interested in, but that will enable us to put those key anchor points at the levers where this is something that needs to be happening outside in services. And I can talk in more detail about that a little later on. But for example, just to contrast, a measure of the percentage of patients, so back one slide once again, so I can talk about the second one. So if you look at the percentage of patients who felt they were involved in decisions about their care, that involves that conversation about that person's care and their involvement in that person's care. So it promotes, just through measurement, the patient choices and that involvement. It draws the attention to what that imbalance of ambitions was, and it stimulates best practice. And that is what I'm really aiming at with our next sort of national suite of measures of how mental health services are performing. It's not so much a keeping tabs as it is that we value what we measure, and we need to therefore measure what we value rather than a suite of indicators that may just lead to the wrong thing happening out there. Right, next slide, please. So this is the ambition. So we have clearly the need for some real-time data that's going to be management information about volumes, about staffing, staff that off on sickness, about occupancy of beds and whether there are sufficient beds available in the country, that about access statistics as well, so we can see where staffing shortages lead to a lack of access to therapies, for example. And then that leads on to patient journeys and transitions, so delays between services, but also really being able to say what is that? Is there a wrong door? How do patients from different equalities backgrounds experience being moved around and through a system, and where are the bottlenecks? But the really big one for me going forward, which we currently don't report on sufficiently, is around patient outcomes and patient experience, which I think is what this whole exercise is about. So the more we can move our annual publications and the information that is discussed in Parliament towards being about those patient-centred ambitions, the better in my books. I think I'm going to stop there, but this is the first RSS talk I've ever given without any numbers in it, although I did manage 2 percentage signs. So thank you for indulging, and please get in touch if you have any comments or any thoughts to offer. Thank you.
Thank you very much, Sarah. And it was actually really nice to have the end bit, which is actually putting a little bit more of the context around it and the looking forward. I mean, we've had a lot of numbers, and I'm sure you have plenty of numbers, but actually this is this real context we need to be thinking about. So we're now going to try and at least tackle some of the questions in the Q&A. So could I ask all the speakers to unmute and come on line now, and just to say, as we're doing that there was on that final slide, but we will actually share with people the fact that all the material will be on the website, and there will be a note going out, so everyone who's registered will know how to get access to that. It's on Stats Usenet. If you don't know how to register, email us and ask us about that. Now, I mean, there's hopefully, and I know that quite a few of the speakers have been answering questions in the chat, and but not everyone can see that, and we will be capturing all of that, and the speakers will get an opportunity after the webinar to look at it in a bit more detail and come back with references and links. So we're not just trying to cover it all now. I mean, there do seem to be several sort of themes coming through in terms of the questions. I mean, one of those is specifically about the level of breakdowns. I mean, there was a question specifically for Tim, but I think it actually does apply to everyone really, in terms of how much is the data available at subnational level, and then also disaggregation to showing age breakdowns above 65 and that sort of thing, because that wasn't in some of them. So I mean, starting off with Tim about subnational level, and just comment on that, but then actually go around the other speakers in terms of any thoughts and comments they've got about that. So Tim first. Yeah,
sure. So I think the presentation I gave obviously focused really on a headline level, but you're right, there's disaggregations are really important. I think on some measures there are some national measures that we currently publish. So in the ONS there's kind of subnational indicators on a range of indicators, including personal well-being. I think also we publish some subnational stats on sort of some mental health indicators as well, which I'll see if I could share some links afterwards. But in terms of the kind of the granularity, I think it's the challenge that you need that kind of large enough data set. If you're using survey data, you need that large enough data set in order to be able to give that kind of disaggregation, which is so important, and we've attempted to do it on some releases where we talk about different groups of the population, but sometimes it's challenging if you don't find a significant difference. Does that mean there's not a difference between those groups? Potentially not. It's just we haven't got statistical power to identify those differences. So there's a real challenge with how we communicate those statistics. So we're not just reporting on the groups where we've got large enough population sizes to cover. And I think that's part of a wider strand of work that ONS is doing on sort of inclusive data task force as well, to try and embed that type of analysis, those disaggregations in more of the work that we do. But yeah, that's just my reflections on that question. I'm not sure who wants to go next.
Yeah, and actually, as I pass it on to the next one, maybe I will sort of ask David next, but I would also quite interesting in terms of I know there was a comment about the speaker. This is very much sort of national level speakers, but there's a range of work done at more regional and local level. And so actually, maybe some of these issues around disaggregation, whether it's subnational or disaggregation and the older age groups, is something that can be or is being done at another level, regional level, and whether or not you actually interact with that sort of work. But over to David. Any comments and thoughts on this particular question?
Yeah, so we do publish data at subnational level. We do some data at regional level. We do some STP level, now ICB level. We do historically did CCG level, which is now sub ICB level. So that data is out there. We also produce some statistics on inequalities as well. So that includes age and gender. IMD, we've recently started to do some stuff around sexual orientation as well. I think probably the main difficulty we have around subnational data is that we are kind of governed by disclosure control, and once we go down to subnational level, people often want to see inequalities data at a subnational level, and it's kind of just finding that balance between what level works without being heavily suppressed. So we do it. It's in a lot of our publications. It's just that when you've got 15 minutes to speak, there's often too much data to throw in there at a national level, let alone going at a subnational level. But we do have it all published. It's all in open data CSVs. We've got some fairly good Power BI products now, which let you look at data at a subnational level as well. And you can get to all them through the links that are in the slides as well. So that's probably where I'm going to leave that one.
Right, yeah, and obviously if those links and any comments can be in what we're capturing with the Q&A, then people can follow up on that. So Emma, just over to you, and maybe you can also pick up on this relationship or links with people working at sort of regional or local level, and how you actually make the connection between the national work and the other work.
Yeah, so in the work we've done, we've tried to break down by region where we can, but again, it's a similar story really to David in terms of numbers and low counts really. I know there was a comment from Aisha in the chat as well around older adults and breaking down the data for the 65 plus age group, and that's also something that's difficult for us to do because again, low counts, we can't always present anything more than what we have. But yeah, it's a tricky one. I'm not sure if I've answered the question there, but yeah, we try to break down where we can, but it's not always possible, I guess.
Yeah, okay. I mean, Sarah, the kind of view from Scotland always seems to be Scotland is sort of better at disaggregating and also better at linking with people working at a more local level. But have you got any thoughts on this?
That's a fascinating thought. I really wish that was the case. I'm not sure. I think I'm just going to have to be perfectly honest. I'm not sure.
Right. Okay. Yes. I mean, so the next sort of set of questions, I suppose, really is around linking it back to the causes. I mean, there are so many things that have been happening. And obviously mentioning Brexit and economic issues arising from that, and then we have all we have the pandemic, and then we actually have all the other economic, world economic issues. I mean, that's you sort of touched on, and is sort of comments on how do you actually disentangle that, and is that something, and whether or not that is something that you actually have to link to more detailed research. So sort of go around the table again in terms of thoughts on, how do you actually try and pin down what some of the causes are and how it relates to those. Tim?
And it's such a challenging question as well, and challenging thing to do. And I think it's not something I would say I would know the answer of how we could do it definitively. I think with taking those two scenarios I talked about, so COVID-19 and then cost of living crisis, the fact that in a perfect world, you might expect an increase kind of in rates of depression, maybe we'll go back down to pre-pandemic levels and it'll be a blip, but we haven't seen that, which shows that is it a longer lasting kind of impact of COVID-19, or is it the financial pressures that people are living in with the cost of living crisis? Is there, we saw some deteriorations in personal well-being in late 2019, which was before COVID-19. Could we attribute that to Brexit? It's possible, but there are probably other factors at play at the same time. So it's all of these things confound, and it's really hard to kind of say what the causal relationship is. I think what we've been trying to do in the research is not necessarily saying this is a cause and effect, but it's the lived experiences of people. So, for example, with the people experiencing some form of depression, it's how are they getting on in terms of the cost of living, how are they getting on in terms of COVID. So it maybe just explains the experiences and challenges different groups of the population are experiencing. But I'm not sure our research has been able to pinpoint how much of this is caused by Brexit, how much by cost of living, how much by COVID. So I welcome if others on this call have an answer to how to tackle that.
Yeah, David, any thoughts on?
I think the short answer is that we don't have any further thoughts, but I mean, I think all we can do is kind of present the data that we have, and kind of there's nothing in our data that can kind of infer a cause, so we can only present what our data is showing. And given, I mean, you can see the trends that we've presented today in terms of things that look closely related to, especially around the lockdown, so admissions and discharges and things like that. And so you can kind of infer potential causation, but you can't definitively say that is the definite cause there. And then, like Tim says, there's a lot of other factors around at the moment in terms of cost of living and Brexit, and all of that makes it difficult to know where the cause is, and in terms of what the cause is. And again, I was just thinking then, like in terms of the data set generally has been maturing since 2016, and actually some of the increase that we're seeing in our data is kind of driven by data quality rather than anything else externally, socially, that might be going on. And unpicking the differences there is almost next to impossible, and you can only present the data as we see it and let people make their own interpretations, I think.
Sarah, you wanted to come in here.
Yes, sadly not with an answer, but with an additional observation in that we often get asked for that intersectionality in our data, and to look at, of people with mental health, with poor mental health, what contributing factors there are, or what underlying characteristics that are coming under the Qualities Act, for example. And I would like to throw that open the other way around and say, actually, people with poor mental health, or many of them, actually qualify as a protected group under the Equalities Act already, as people who live with limiting long-term conditions. And that actually we should be looking the other. So rather than sort of what the factors are that cause the mental health, we could also be asking the opposite question, saying actually, for the group of people that are protected under the Equalities Act as disabled with a mental illness, what are we doing in all the other aspects of life? And are we actually acknowledging them as a group in conversations about the economy, in conversations about physical health, in conversations about housing and social care, etc., rather than mental health always being a consequence? I think we could, if we built it in our policies as an underlying cross-sectional factor, I think that would change the conversation and be quite helpful actually for people with mental health issues, whether they then are also from an ethnic minority group or additionally disadvantaged. Thanks.
Mm-hmm. Yes, yeah, that's a good thought. There's Emma, anything on this?
No, I don't think I've got anything else to add.
Yeah, I mean, there's one or two specific things around what you're actually measuring. Now, there's one sort of comment around, looking at contacts, because that's the thing you've got, but but obviously contacts is this demand or supply generated. I mean, this applies in all areas of healthcare, obviously, and, you know, is fewer contacts reflecting less availability? Is there something that you actually look to explore there? And also another comment around in terms of the private sector, is there anything that you're picking up on in terms of bringing that into the data? So in terms of what you're able to measure. Tim, go to you. Have you got thoughts on that area?
I mean, I have thoughts, but maybe if I can come in at the end, because I think there might be others on the call who might be better placed than me to answer that one around sort of service access in particular. I don't know, Emma, if you want to.
Yeah, I mean, it's a tricky thing, and I think it with the data sets that we use with like for IAPT in particular, the only thing we can comment on when we're looking at IAPT are the people that are in IAPT at that point in time and have been referred to IAPT for treatment for their mental health. So any conclusion we make from that research is about that group of people that are within that service. And it's kind of where, I guess, we need people to be doing other research in mental health, like Tim's team, where they do the survey side of things, to report on more of the general population and the mental health within that more generally, to then be able to look at, okay, there's a people in this particular treatment path and how their experiences lie. So I think we can't, with the admin data on its own, we can't tell the whole story, and probably with the survey data on its own, we can't tell the whole story, but in combination, I think there's a lot more strength, I think.
So and does that then link in? I mean, presumably there's a lot of research that, you know, when you're trying to look at that level of detail, that's not something you get from a sort of national admin data. You need to be linking in with more detailed research, presumably, or there are research data sets that you're bringing in, which gets back to the other people or other analysts or other data that you might be linking in with. Any thoughts or suggestions on that?
Yeah, I don't mind coming in on that and following on your point as well, Emma. I think it's a really good opportunity, and I think the opportunities that afford us now are maybe different to where we were 5 or 10 years ago in terms of being able to link those assets, so linking survey data to kind of actually service access data to see where you might have treatment gaps. And I think there is some good work that's already gone on in this space, but I think asking people, do you have a mental health condition, is not necessarily going to be the best way to do it. It's the screening tools that we have to kind of identify people who maybe are exhibiting symptoms that maybe would then kind of, you know, asking then have linking that to people who have gained access to systems. You kind of seen the unknown prevalence with the known prevalence, and then the known prevalence who are in contact with services. So I think there is research in that space already, but there's a lot more we can be doing as well.
Yeah, so I think, again, with the IAPT publication we published in June, we used the household longitudinal study to give us a kind of general prevalence of common mental disorders, and that's people self-reporting their mental health, and then we've got the people that have ended up in IAPT, and that's how we've looked at the sort of inequalities and access. But yeah, like Tim said, there's potentially kind of the missing bit of people who are maybe going to their GP and being diagnosed or undergoing those screening bits to sort of give that entire picture at the moment. So yeah, there's definitely more work to be done and more opportunities to sort of link up these data sets.
And then what about everyone's the private, anyone, I mean, is that, I mean, obviously it's an issue in other areas of healthcare. Is that something that needs to be picked up on in terms of private healthcare, in that there are many ways of people reaching out for treatment if they have, mental issues. The private sector is a whole undata collected area. Anything that anyone's got to contribute or comment on there? And also then throw in the fact that there's an issue around social class, wealth, income, and how that and where people live, because actually in terms of the private sector, that obviously interacts with, you know, the amount of wealth people have to actually pay for that. So Sarah, sorry, yes, do you want to come in there?
I'm going to do my classic thing of saying "and" rather than answering, and that is that you may have noticed that I glossed over the request to us to measure what is going on in the third sector, which I think in mental health is a huge provider of services actually. So we are looking at a fraction of what of the mental health support activity within the NHS compared to what the third sector provides as well. So sorry, Deanna, that's yeah, but yes, please.
Tim.
I mean, there's two ways we can tackle it. One, probably by trying to get access to kind of third sector kind of data on this, but I would imagine the legality and the ethics of that is obviously very challenging. I mean, surveys are often our first port of call when the question can't be answered elsewhere, and there's that ability. So we have done some work in ONS on sort of winter pressures and understanding people's access to sort of non-NHS services around their health, but health in more broader terms. But I guess there are ways we could try and ask people about the different types of service routes they've gone through, and I imagine there are some services that do that. I guess the challenge though is people's awareness of those services. So is it an employer-based system that you can get kind of counselling from, where that gets picked up in people's awareness, whether that's a private healthcare or not, which presumably it is. So it's just, I guess people have got so many different routes to care and support, and they may not be aware where they fall in terms of our definitions of private and sort of NHS care. But yeah, I guess the short answer is I guess the survey could attempt to answer it, but it's whether that's the most appropriate way as well.
Yeah, and while you're on, there was another sort of specific question around how this feeds into the National Health Index or the other index. You know, this, how does this data link into any of the sort of indices? Do you want to just pick up on that, Tim, while you?
Yeah, of course, and I think there's lots of different ways. I guess we're blessed at the moment. There's lots of indicators and frameworks that we can use to kind of track these things. And I think in the last few years we have developed this sort of National Health Index, if you will, for England. And I think the wider work that we're doing at the moment, measuring quality life in the UK, these are kind of tools that I guess are available to us, and there'll be a bit of overlap between them. But I guess that it's making sure that these all sort of complement each other and don't necessarily tell different stories. So I guess the index is a useful tool to see how things have changed in terms of index terms since 2015, whilst wider kind of tools we have maybe paint a picture in terms of prevalence rates of different issues. But I think if I remember the question, it was related to kind of how our review would kind of align with that index. And I think it's just something that we're trying to tie all of these wonderful tools together and make sure we're telling a coherent story as a government body, I guess.
I see there's a sort of response coming in on the chat about obviously if the services, if are commissioned by the NHS, then there should be in the SLA a data sharing agreement. I'm not sure that always happens, but that really should be something at a national level to say that if there is, because quite often these things are referrals, so that's something around the kind of like the private sector one as well. So yeah, okay. Now we're almost out of time. Masses more in the chat that we will capture and then pass. And so anything, if you've got links, and also Sarah, you mentioned some consultations or something, it would be really good to have links to that to see what's going on there. So there will be a more detailed report. But if I can just then go round you for any final thoughts or suggestions before we close. Sarah.
I'm just delighted that this could happen finally. And lots of food for thought, lots of links. My browser is exploding with new options. I think I particularly need to have an offline chat with Emma about some of the data linkage ambitions that I want to kick off in Scotland, because there's a huge amount of power in that. Yeah, while we work on completing some of our patient level data sets that for some of the services. But yes, I think all in all, it is, for me, it still is that proportionate measurement and actually using measurement as a lever for creating the systems out there that we want, rather than just out of curiosity, although I'm naturally the curious type. So, but it's been great speaking with all of you. Thank you.
Thank you. Thank you. Emma, final thoughts on how this is going forward? Or
yeah, I think it's been a really interesting webinar, and I think it just shows how much is going on in this space and how much potential there is for work in the future. I've been really interested to see the comments that have come through, and I'm happy to respond to any in this sort of Q&A when we can. But yeah, been really glad it's happened as well, Sarah, and more than happy to chat with you afterwards. And if anybody else in the audience has further comments or wants to link up, then yeah, please get in contact.
okay, great. David.
Yeah, I'd just like to echo what people have said so far, really. Like, thanks for having me let him present. And if anyone's got any questions about anything that we've presented as an organisation or any of our data sets, then please do let me know. And if we can contribute anything to any of the mental health working groups or anything, then do let me know as well.
Yeah, great, fantastic. Tim.
Yeah, to echo everyone else, but I think really some really useful and interesting questions as well, which I've scribbled down some, and I'll hopefully we'll get access to all of them. I think for me, it's just you know, there's some brilliant work that's going on, being talked about here, and I know there's even more brilliant work that we haven't even touched upon today. And I guess it's continuing some of the things that we've been able to do during the pandemic about more timely data, more access to data, but also making sure that it kind of has that granularity that goes with it as well. I guess that everyone's asking. Probably my final thoughts on that as well.
Great. Okay. Well, we are out of time, so thank you very much to all the speakers, but also thank you very much to everyone, the comments and questions. There's a lot to pull together in the Q&A, so we'll try and actually make sure we get that together. The presentations we've posted quite soon, but it'll take a little while to actually get the meeting report and the QA together. And obviously the speakers will have a chance to add a little bit more comments on that. And I noticed that Emma also did a little kind of almost like a sort of trailer for our next webinar in this series, which is on adult social care statistics. And obviously dementia and mental health is an issue within that as well. But we're still putting together a programme for that, but hopefully that will be after Easter. So look out for that on our website. So you can actually find information on the RSS official stats information and also the events. But for more detail, go to the Health Stats User Group webpage, which is within Stats Usernet under the Health and Care section, the webinar material, which shows all the past webinars and also anything that we're planning to do. So if you don't know how to do that, email us on that webinar address, webinar@hsug, or contact the RSS official stats who'll put you onto that. So look forward to further exchanges and further discussions on this topic, and I think maybe we're going to have to come back and revisit it in a while. So thank you very much to everyone for all your contributions. So I'll close the webinar now. Thank you.